we are live, Senators.
All right, good morning. This is Senate Health and Welfare. It is April 4th, and we are taking testimony. We're starting a little late due to floor time. It's crossover, so we spend a lot more time on the floor with bills. So this morning, we're going to be looking at S-190 and taking testimony on that bill related to end-of-life choices and residency, out-of-state residency. We had a walkthrough on the bill with Ledge Council and looked at the program as it currently exists. And now we're going to be looking at what has come to us. H-190, I said S, H-190 was come to us from the House. So Dr. Barnard is here. I believe you are first up for testimony, so welcome. It's good to see you.
Thank you. Good to see you too.
I think our committee is going to introduce, we're going to introduce ourselves once so that everyone here will know who we are. So I'm Senator Lyons, chair of the committee from Chittenden Southeast.
Senator Dave Weitz, representing Rutland County.
Senator Martine LaRocque-Ulick, representing Chittenden Central. Diana Ruth Hardy from Avston.
Terry Williams from Rutland County.
Okay, so Dr. Barnard, why don't you introduce yourself for the record, and we'd like to hear your testimony.
Thank you. Can everybody hear me okay?
Yes.
All right. I was hopeful to be there in person to see some both old and new friends, but clinical needs got in the way. So I appreciate the opportunity to talk to you remotely. And also, I'm going to try to keep my comments brief because I know you have a busy day and I want to be sure to leave time for questions. So my name's Diana Barnard, and as I sometimes like to brag, my primary qualifications for being before you are that I'm a lifelong Vermonter and I grew up on a dairy farm, which taught me a whole lot of life lessons and certainly about death. But in addition, I happen to be board certified in family medicine and also board certified in hospice and palliative medicine. I've been practicing medicine for 29 years now, post-training, and the last 14 years of those have been dedicated to caring for patients and families that are dealing with serious illness. I'm an associate professor of family medicine at the Larner College of Medicine at UVM, and my clinical work involves being the lead palliative care physician at UVM Health Network's Porter Medical Center, which is a critical access hospital in Middlebury. And I also work at Helen Porter, which is the skilled nursing facility right across the street. I've been on the board of directors of Patient Choices Vermont, which is the lead advocacy organization in the state since its inception. And I'm also on the clinical advisory panel of the American Academy of Medical Aid in Dying since its inception in 2020. Some of you know, certainly Senator Ayer knows that I was, and Ginny also, that I was actively involved in the multi-year effort to pass our medical aid in dying law. And we are now coming up on 10 years of experience that shows that our law is working well and as intended. And with no instances of misuse or abuse. But like most things in life, things change, and a lot has changed in the past 10 years. There are now 10 states, as well as the District of Columbia, where medical aid in dying is legal. And there is a very robust academy, which just held its second national conference on medical aid in dying, which I attended in Portland, Oregon. There are standards of care and clinical guidelines and a great deal of experience to assure that the practice is done and done well. So, you know, for nearly 10 years now, I have been able to incorporate medical aid in dying into the comprehensive care that I offer my hospice and palliative care patients for those who are interested or who qualify. And I do want to take just a moment to remind you all of the many things that I have learned in caring for people with serious illness. And the first one is the unique and highly individual needs of patients and families for those with terminal illness. No two are the same. Each person has their own unique way of suffering. And we really need lots of tools in the toolbox to make sure that we have the ability to respond to the diversity of experiences that patients face. I also want to clarify that the patients I care for, they want to live. They are desperate to live. And it really is only when their illness is progressing and they're running out of treatment options that people start to realize that when they have to accept that they're dying, they also want a say in how they will die, which seems to me an appropriate thought. Many of my patients are comforted by having some measure of control over what happens as they are navigating their one precious life as it comes to an end, and their one shot at having the kind of death that honors the person that they are and the way that they have lived. And that can look so different for different people. And for a small but important number of people, it includes the possibility of hastening their death when suffering becomes extreme and difficult to manage. Just a brief reminder of the circumstances that allow somebody to be eligible to consider medical aid in dying. You must be over the age of 18. You have to have a terminal illness and been given a prognosis of less than 6 months. You have to be capable of making a voluntary and well-informed decision. You have to make 2 separate requests to a prescribing physician more than 2 weeks apart. You have to see a second consulting physician to confirm your eligibility, and you have to put your request in writing, which is witnessed by 2 uninterested parties. So while most of my patients live in Vermont, I also regularly care for patients from New York. And over time, as I've been having these conversations with people, I have come to see the injustice of not being able to offer all of my patients the same comprehensive care and spectrum of options to attend to their unique suffering. And this is certainly especially true because many patients that I care for travel out of state to seek care that is consistent with their values and their own preferences. For example, a patient going to Dana-Farber to get a second opinion about their cancer care. So some of you may recall that when we passed our law, we modeled it over the experience in Oregon. And at that time, Oregon had a residency requirement. Oregon no longer enforces their residency requirement. And I now have come to the realization that I need to acknowledge that our law was mistaken in trying to limit medical care by the state in which you live. I am not a lawyer, but I'm a doctor, and doctors know when they need help and guidance, and smart lawyers that I have consulted have helped me to understand that our law is unconstitutional in this regard, and we have an opportunity to fix it. And that's what we're asking of you today. I think it's really important to acknowledge that there is ongoing need for education and support for Vermonters who are seeking information or access to medical aid in dying. And we know that meeting the needs of out-of-state patients is going to create an additional and different set of needs and education and support. And I want to assure you that physicians like myself and advocates like Patient Choices Vermont are committed to, and we're already working on ways to be able to meet this increased need and make sure that we are practicing the best possible medical care possible. So with that, I will just say that I'm, as I said in the beginning, so proud to be a Vermonter and to be a witness to the legislative action that you guys are doing and the hard work that you do to try to do the right thing. And in this case, I think the right thing is to pass the bill removing the residency requirements so that I can assure that all patients I care for have equal access to the medical care that they want and deserve, and to honor individual choice. So I think I will stop there. I'm happy to take questions if you have any now, and I'm also hoping to stay on the call to answer questions that may come up later.
All right, thank you, Dr. Barnard. I think we have one question, and what I'm going to suggest is we try to keep our questions pretty focused, and then as we move along, if we have time today, we'll have a greater opportunity for more questions and discussion. We'll probably have to come back to this another day, but Go ahead.
Thank you, Dr. Vines. You mentioned that in your testimony that laws were unconstitutional. Can you elaborate on that?
As I said in my testimony, I am not a lawyer, but I do understand that there are different provisions of the Constitution that the residency requirement is in violation of, and I will look to other members of the team to speak to the legalese, which frankly, I don't have comprehensive knowledge of.
Thank you.
I don't think I'm the best person to answer that question.
Okay, we'll surely have lawyers to comment on that particular, perhaps Edge counsel. Okay, so we're going to move on, and we have Tony. Is it Kading or how do you pronounce your last name?
Katie, I'm sorry.
Okay,
Tony
okay.
Kading.
Why don't you come up to the hot seat? Thank you for being here.
Thank you for inviting me. Good morning. My name is Tony Kading. I'm here to ask for your support for S26. I live in Worcester. I am a nurse by training. My clinical background is oncology, and I have a graduate degree in health policy. For the last 5 years, almost 6 years, I've been a volunteer at Patient Choices Vermont, which you probably know is the organization that does education, focuses on education about Act 39. The role that I have at Patient Choices Vermont is to manage the helpline. So that means that every day when I answer the phone or look at the emails, I hear from patients and their families who want to know, how does Act 39 work? Or where can I find a doctor, or what their options are? And I also hear from clinicians, most specifically doctors and nurses, generally asking questions about protocol or where to find resources that can support their work. In most cases, I can answer their questions because I've been doing it for long enough, but if I can't, I lean on and depend on a panel of consultants that work with Patient Choices Vermont, that are doctors, that are nurses, pharmacists, social worker, and lawyers. And I connect them with the caller, and their question hopefully gets answered. I should mention that Patient Choices Vermont is a not-for-profit organization and almost completely voluntary. All of the professionals that I just described volunteer their services for this. Patient Choices Vermont serves as the primary source of information in Vermont about Act 39, and was the organization that helped usher the bill into law back in 2013, but since then has existed solely for education and work with access. Please support Senate Bill 26. When I first started learning about Act 39, which, by the way, I consider a gift to patients who need it, I was kind of surprised to discover that Act 39 could help a patient standing right here, but it might not be able to help this patient standing a foot away if there was a state line between the two. And that just seemed unthinkable to me from a nursing perspective. I also think about a physician's waiting room where two patients are sitting there, and when the physician comes to assist, it may be able to help one of those patients and may be prohibited from helping the other patient. And again, that just goes against everything I know about healthcare and frankly about being an American. So I think it is not fair to allow a state border to decide who gets care and who doesn't get care. And I think it's not fair to deny out-of-state patients the access to the compassion and peace that is possible through Act 39. The voices of people who call Patient Choices Vermont are always full of anguish and fear and desperation. I think the removal of the residency requirement in Act 39 is really a matter of equity, a matter of utility, and a matter of kindness. As a practical matter, Patient Choices Vermont can play an important role in the rollout of S26 by being an educational vehicle. We already are in touch with clinicians, both doctors and especially hospice nurses, and we can prepare them for that role and help them navigate the intricacies of it and perhaps let them know how it might impact their practices so that they can prepare for it. In all of our communication to both patients and clinicians, one thing that we are committed to being very careful of is that being clear that all activities, all steps of Act 39 must occur in Vermont. And that's from the very start of receiving the request for medication through the writing of the prescription to the actual ingestion of the medication. To be legal, it must be in Vermont, and we're clear about that, and we want to be clear about that in our education. So I guess in closing, you may have heard people say about Act 39, even if I never use it, it gives me such a sense of peace knowing that it's there in case I have to use it. So on behalf of patients and myself as a nurse, thank you for your support of Act 39. And thank you for your willingness to consider leadership in this national trend to remove residency restrictions from healthcare.
Thank you, Tony. It's very good. Do you have your testimony in writing?
I do, but I've been scribbling on it. Can I send it to you?
Absolutely. Send it to Alex and then
Okay.
he'll have it posted.
Okay.
That'd be
Happy to
terrific.
do that.
Thank you. Alex is here, but he's behind the screen. Okay, thank you. It's great. We're going to try to keep moving and with apologies to folks at this point. So Melissa Stacy and Amitai Heller, are you speaking together? How are you coordinating your testimony? I guess is the question.
So I'll be speaking on behalf, good morning. I'll be speaking on behalf of Compassion and Choices. Amitai is here to answer any questions that you may all have, and knowing that given today's schedule that they may be after today, but I will be the only one testifying.
Okay, thank you. That's good, and that will help consolidate things for us. So why don't you introduce yourself for the record, and we welcome your testimony.
Wonderful. Thank you. Good morning, Chairwoman Lyons and members of the Committee on Health and Welfare. My name is Melissa Stacy. I'm the Regional Advocacy Manager for the Northeast at Compassion and Choices. We're here today in support of H190, an act relating to removing the residency requirement for Vermont Patients' Choice at the End of Life laws. Compassion and Choices is the nation's oldest and largest consumer-based organization. We're working to improve end-of-life care, expand options, and empower everyone to chart their end-of-life journey. And as I mentioned, Amitai is here to answer any questions, but will not be testifying. At Compassion and Choices, we advocate for legislation to improve the quality of care for terminally ill patients and affirm their right to determine their own medical treatment options as they near the end of their life. We support H190 as it would remove a major regulatory roadblock to accessing Act 39, the patient choice and control at the end of life. Vermont is and has been a leader in the end-of-life movement. As you know, in 2013, Vermont was the first jurisdiction to authorize medical aid in dying through the legislative process. The law was amended last year in 2022 to find a better balance between safeguards intended to protect patients while ensuring that terminally ill individuals have access to medical aid in dying. We have another opportunity to be a leader in the end of life movement with H190, which your colleagues in the House passed by voice vote last month. On August 25th, 2022, Compassion and Choices was part of a team that followed a lawsuit on behalf of Linda Bluestein, a terminally ill Connecticut resident, and Dr. Diana Barnard, who you just heard from, a Vermont physician specializing in hospice and palliative care, who is also an associate professor of family medicine at the University of Vermont. The suit alleges that the residency restriction violates the U.S. Constitution's guarantees of interstate travel and commerce. Earlier this month, the state of Vermont defendants settled the case, I should say this earlier in March, allowing Ms. Bluestein to access medical aid in dying in Vermont without establishing residency. The legislation before you would ensure that all terminally ill patients in Ms. Bluestein's position would have the same access to this important healthcare option in Vermont. Additionally, in March of 2022, Compassion and Choices reached resolution in a similar case filed in Oregon, as Dr. Barnard mentioned earlier, Gideonese versus Brown. The state of Oregon settled the Gideonese case, allowing the legislature there to work toward removing the existing residency requirement from the state's medical aid in dying law, rather than prolonging the process through unnecessary litigation. This settlement has resulted in increased access to crucial end-of-life care, as you've heard, an extremely important option for the many non-Oregonians already receiving all of their other health care across state lines. Compassion and Choices believes that medical aid in dying should be available to all qualified patients regardless of their zip code. The process of establishing residency in a new state while terminally ill is extremely burdensome and an expensive process that no one should have to endure, especially at the end of life. Further, the residency restriction is out of step with nearly all other medical care provided in this country. At present, the Vermont Patient Choice and Control at the End of Life Act contains statutory language that limits the use of the practice to in-state residents. However, firsthand experiences from doctors, as you've heard, and patients, and decades of data make it clear that the residency restriction within the Vermont Patient Choice and Control at the End of Life Act functions more as a barrier to access than as a safeguard. We urge your support of this critical legislation, and I appreciate you for taking the time to consider this issue and my testimony, which I've also submitted to Alex. I'm happy to answer any questions today or be a resource in the future. Thank you.
Well, thank you, Melissa. And we do have your written testimony, and thank you for discussing the two court cases that both in Oregon and in Vermont. Very helpful. And just to offer some clarity, because I know when Tony was speaking, she talked about S26, which is the companion bill to H190. So we're looking at H190. I know you know. I just wanted folks to know who are listening and watching, and that was the case. So unless there are some burning questions, I think we're going to move along, and then we'll come back around. If we have some time, we can have a broader discussion with questions and hopefully answers. I like answers. So Cindy Brazesi is here. She is, why don't you introduce yourself, Cindy, and thanks for being here with us. It's good to see you again. And you're muted. Now
Yep,
you're not.
I got it. I'm just trying to move my computer. I'm at my UVM office today, and the lighting is not great here. So my apologies if I'm in the dark.
You look fine. It's terrific.
So thank you for the invitation to speak on H190. I am Cindy Brazesi. I am the Executive Director and Ethicist at the Vermont Ethics Network. I also work, as I am today, as a clinical ethicist here at the University of Vermont Medical Center. And just so everyone's aware, I'm also on the American Clinicians Academy on Medical Aid in Dying. There is a group of individuals from across the country who have formed an ethics consultative service for the states who have medical aid in dying as a legal option. And I am the ethicist from Vermont that sits on that broader committee comprised of folks from across the country. So just so people know that I wear that hat as well. Typically, as the Vermont Ethics Network, we generally do not, and we aren't necessarily taking a position per se on Vermont's law on medical aid in dying. We have served and continue to serve as a resource for Vermonters to be able to obtain factually accurate information about the law. I did not testify on this bill when it was in the House. And so my guess is that you're interested in sort of an ethical review, so to speak, of the question about residency. And on that front, I would say residency is largely a justice issue through an ethics lens. And by that, I mean, ethically, we have obligations to treat patients who are similar in ethically relevant ways. We have to treat them similarly. And patients who are different in ethically different ways, we would treat differently. I don't see residency as being an ethically relevant characteristic as it relates to access to medical aid in dying that would warrant different treatment. So from that perspective, I have no objection, if you will, to the removal of the residency requirement. I think, as Dr. Barnard mentioned earlier, as a practical matter, I think this type of change has implications as it relates to the informed consent process. And by that, I mean what prescribing physicians will need to discuss with patients who are seeking this option in terms of risks, given that the current protections that the Vermont law affords to patients are only afforded if they are in Vermont. So if a patient from another state were to return to their home state, the protections that Vermont law affords to patients in terms of insurance, what the death certificate will say about the cause of death, none of those protections would travel with the patient if they were to take this prescription and travel back to their home state, as I understand it. Similarly, I think there are protections for and the immunities that prescribers and pharmacists who fill these prescriptions and consulting clinicians that they all are afforded via our law. If the patient returns home, I think it will be important for those clinicians, pharmacists, et cetera, to make sure that they review the legal parameters as it relates to serving non-residents directly who may return home, whether it's through telehealth, and what those potential liabilities may be for them. And those are legal questions, not really ethics questions, but I can see the need, as Dr. Barnard alerted to make sure that we are providing good education and support for clinicians who may be considering writing prescriptions for patients who are requesting it, who are from another state. At the end of the day, though, all participation remains voluntary. And so if a clinician or pharmacist feels uncomfortable in any way, they're under no obligation to participate if they feel like they can't do so in a manner that makes them feel protected. So I think from an ethics perspective, those are the things that come to mind relative to this particular change. And I guess I can leave it there and ask if there's any questions.
Okay, thank you. I think there will be questions. So what you're suggesting is if a patient comes to Vermont and is working with a physician and others in the state for witnessing and so on, and receives the medication and then takes it out of state, goes back home to administer the medication, then there's no protection for that patient.
Not if the state they're coming from does not recognize medical aid in dying as a legal option in that state, to my knowledge, because our laws only operate in Vermont. But I would certainly defer to, you have legal experts on the call, I think, and you probably will be hearing from others who will have more ability to speak with authority around how those laws work. But I think it will be important to make sure that if this change is made, that information is conveyed to prescribing clinicians so that they're well informed about what their own risks may be, and can communicate also to patients and families what risks they may take on if they were to leave the state with these medications.
All right, thank you. Well, this is something that we will continue to follow. We'll follow up on that, and maybe we'll circle back in a little while. But thank you for your thoughts. But in terms of the ethical considerations around state lines, you're not seeing a concern.
Ethically, I don't think this really changes anything in terms of physicians' ability to participate. It's because ultimately it becomes, as it has always been, their choice whether or not they want to assist in medical aid in dying. So, I don't think that the removal of the residency requirement is problematic per se. I think there just are logistical, practical issues that need to be addressed and clarified so that clinicians can feel, or physicians can feel confident if they choose to move forward with agreeing to do this for someone who's from another state.
Okay, thank you. And then my last question is, could you please send your testimony in to Alex so that we have your comments?
Happy to do that.
Thank you. All
Thank
right,
you.
all right, thank you. So we're going to move on, and we have next on our agenda, Mary Hahn Beerworth. So why don't you come up to the hot seat?
You're on the list first. Well, thank you.
Thank you for being here.
Thank you for having me. Thank you for this opportunity to offer testimony on House Bill 190. I was a lobbyist and I witnessed the 13 years of discussion on physician-assisted
Can you just
suicide.
give your name and your title?
I'm sorry. My name is Mary Hahn Beerworth, and I'm a lobbyist for the Vermont Right to Life Committee. And I have been a lobbyist since 1996, and I witnessed the 13 years of discussion on physician-assisted suicide in this body and the numerous votes in both the House and the Senate. I want to point out that assisted suicide was and remains a matter of contention. There continue to be legitimate and serious concerns. Members of this body were as deeply divided as your counterparts in the states neighboring Vermont. And I will just, as an aside, mention Connecticut, where Linda is from. Bloomstein, I think the name is. And that particularly is a very strong opposition from the disability community. Not Dead Yet and another Second Chances. I think they testified here in Vermont, and they have been very active and opposing in their state allowing physician-assisted suicide. So it isn't something that should be taken lightly, or is it simple? Over the years-long debate, both sides agreed that safeguards needed to be in place to protect the vulnerable, and the requirement for a patient to be a Vermont resident was uncontested. To be clear, Vermont Right to Life opposed the underlying concept behind assisted suicide and opposes the move to remove the residency requirement, as there are still no safeguards that protect vulnerable patients from coercion. Proponents of the law continue to claim that all is working well here in Vermont. Yet I include in today's testimony the words of Dr. Diana Barnard in her presentation during the UVM Medical Center Grand Rounds on February 28, 2020. On page 14, and that's included in what I'm sending to Alex, I have the transcript in full, but I'm pointing out a few places where are of interest. Dr. Barnard stated, in the early days, we were using rapidly acting barbiturates, which were lovely. Secobarbital, pentobarbital, very quick acting, put you in a coma, cause respiratory depression and death very peacefully and very quickly. She continued, those medications are no longer available in the United States due to terrible things like the medicine being used for executions. Further evidence that Dr. Barnard is correct can be found on page 18 of the Oregon report, which will also be attached to my testimony. That states that secobarbital has been unavailable for use in assisted suicide since 2019 and pentobarbital since 2015. Dr. Barnard, who you just heard from, goes on in her presentation to discuss the drug protocol that was developed called DDMP2, which is a combination of digoxin, morphine, and propranolol. So you are seeing, she says, a combination of medications sort of designed to affect different parts of our body that are keeping us awake, designed to help you go to sleep, be in a coma, and then end your life through respiratory depression or cardiac death. She goes on to discuss ongoing experimentation with the drug combinations in California. And on page 15 of her presentation to the UVM Grand Rounds, she discusses rectal use of the drugs, though she herself, at that point in 2020, had not used that developing procedure. In her closing remarks, she mentioned side effects such as prolonged dying and regurgitation of the medications. Vermont has recently been mentioned in a UK Daily Mail. I will have that in my testimony as well. The article discusses the fact that Oregon is offering terminally ill people from out of state a deadly cocktail of drugs at Dr. Gideon Neese's assisted suicide clinic. You heard his name in the testimony, but he has an assisted suicide clinic. Vermont is mentioned as likely becoming the next in line to establish such a clinic in the Daily Mail story. If H190 is to move forward, I offer the following concerns. Due to the experimental nature of the drugs currently being administered, what liability could the state of Vermont incur should the drugs fail to end the life of a patient? According to the Oregon report, page 18, at the time of death ranged from 3 minutes to 68 hours. The data, however, is only available when a healthcare provider is present, 165 out of 278 cases. Also, table 4, page 18, bullet 6 clearly states, quote, patients who regain consciousness after ingestion are not considered a Death with Dignity Act deaths in Oregon and are not included in the other columns in this table. So the questions continue. Will the patient seeking the lethal dose from a Vermont doctor simply find a willing prescriber online? Will patients from out of state have to come to Vermont to fill out the paperwork? And I think that was pretty clearly answered by one of your last witnesses. It is clear from the data that a number of patients will procure the lethal dose, but never actually use the prescription. What if a patient takes the lethal dose back to their home state, but doesn't use the drugs? What then becomes of the prescription? What if the drugs fall into the wrong hands? There is no possible way to enforce any safeguards if drugs from Vermont are taken to another state. An example of things going bizarrely wrong happened in the state of Colorado and can be found in a report by the Journal of Emergency Medical Services from late last year, 11/2022, also will be in my online testimony. If the drugs are taken and death occurs in Vermont, what happens with the body? I spoke with a retired funeral director about H190, and he raised the concern that patients who come to Vermont to apply for and ingest the lethal dose can then simply leave their remains for the state of Vermont to dispose of. This funeral home director has dealt with abandoned bodies in the past and outlined the search for relatives and the costs that were subsequently absorbed by the state. A suggestion is that patients who want to come here and ingest the drugs ought to have a plan for shipping their body back home. In closing, Vermont Right to Life fully expects to return to this and other committees of the House and Senate in the future as a witness to the further erosion of safeguards. The erosion of safeguards was predicted in 2013, and the question is, will that erosion continue until, much like Canada, the lethal combination of drugs are available to anyone of any age or circumstance who requests them? Thank you for allowing me, on behalf of the Vermont Right to Life Committee, to become part of the historical record as Vermont continues down the slippery slope of legalized assisted suicide.
Thank you for your testimony, and you will get your information to Alex. That would be very
Right
helpful.
away. Yeah.
And understanding that our concern here is on the residency requirement. I think you've spoken to that. You've also spoken to other areas of the current program, which we are not evaluating at this time, but have identified some things that perhaps
I
we will
understand.
talk with our physicians and others about.
Thank you.
And generally, people in state or out of state are not aware that sort of the magic dose of Seconal and phenobarbital are not available.
Yeah, thank you.
Thank you.
David Englander is here. Welcome back.
Good morning. I'm glad
It's still morning.
It's still morning for a few more moments. For the record, my name is David Englander. I'm the Senior Policy and Legal Advisor to the Department of Health. Given a limited amount of time, I'm inclined to abbreviate my remarks and then talk about maybe background of the department's role later. What would be the most helpful to the community?
I think you attenuate what you need to, and then we have some information from you on our webpage.
So to begin, the Department of Health and Administration support H190. Being able to receive medical care, irrespective of one's zip code, is a necessary component of health equity. The Act 39 actions taken under Act 39, manipulating dying is the only medical care that has a residency requirement in Vermont. And in fact, as I understand it nationwide, but I can only speak to Vermont law. I'm trying to put this briefly to paraphrase the former chief medical examiner, Dr. Shapiro. He said, and essentially what he said when we were talking about this 10 years ago was, a physician and a patient spend a lifetime making decisions and having discussions. This is simply the last discussion, or the last serious discussion that a patient and a doctor have, and it is both profound and everyday. And so removing the residency requirement simply normalizes this kind of care. So I'm happy to stop there with our support. I'm also happy to give some background on the Act and how it's worked. I actually, I've been working with Cindy, Dr. Martin, and others since the beginning of the Act on implementation. But I'm happy to just take questions, whatever the committee would like.
Why don't we take questions? And I know that you did bring the report in, and it is under your name on our webpage.
Yes, so the department, I'll say this, the department has a very limited role. We do collect the documents that are required to be filed by the doctor and the patient. And then we provide a biannual report that provides a kind of high level surveillance of what we've collected in a way that's HIPAA compliant.
I guess the folks who have questions, my observation is that the people who have been wanting to be in state have wanted to be here with their families because their families are here. And so to think that they might pick the medicine up and go back home right now it doesn't seem realistic, at least. But, so questions committee.
I was only going to say, since three of us are new this session, it would be great to have some historical context. And I mean, you mentioned that you might do that, I don't know, today or another time, but that would be really helpful.
Yeah, I can give some of that. And Senator Ayer is here. But let's ask questions of David Englander. Do you want to add some historical context?
Well, I think Senator Ayer and certainly Jen and the Dean Copper just also could also provide historical background. I can tell you briefly that the original proposal actually was quite a comprehensive law that looked a lot like Washington ordinance, and it was greatly simplified in the waning days of the legislative session, which still required a stepwise process that Dr. Barnard described, and that all decisions have to be made. It's important to know that all decisions are made by all parties voluntarily at all times, and that all documentation has to be filled out by the patient and the doctor, and is filed with the Department of Health. The Department of Health has all those documents. All those documents are confidential. They cannot be sought under the Public Records Act. And so we were very careful when we worked on the 2015 Act that required a biannual report to ensure that they provided a very high level of information. So when you look at that report, which is in my testimony, I'm pointing to Alex's computer as if it's only sits there. It's like cancer, ALS, neurodegenerative disease. It doesn't say what kinds of cancer, because in a place like Vermont, that information could be potentially identifiable. The department does interact with, we do receive calls. We do provide, in fact, I worked with Dr. Barnard and Cindy Brizzi 10 years ago, creating FAQs for the public, for providers, and for healthcare entities. And the number one question we get at the department is, what does it mean to be a resident? We get that from patients, we get that from doctors. And the original law has passed in Act 39, doesn't specify, simply says as a resident. So the department has tried to be helpful, provide guidance, and provide a lease, a gas bill, a driver's license, but there isn't a X number of months, X number of years, etc. So I said it only to say that it is something about which people are extremely curious as doctors and patients in seeking this kind of care. The department, it's useful to know that the department does do follow-up when we receive let's say, one fewer, two fewer forms from a visit from a patient or a doctor that we get for missing forms. We'll reach out to that doctor and say, was this your intention? Just so we have a complete file, make them aware of their rights and obligations without giving them legal advice, of course. We also, it's important to know that we have received no reports of coercion, or we've never tried to falsely file a signed document. There's also been no complaints filed with the Board of Medical Practice for an MD or PA, or PAs can't, but for an MD under the Act. So I think
That answers your question.
probably a long answer.
I'll just say, the second session I was here, I introduced this bill. And then it took that long for us to work together to move it through. It took a long time. Go ahead, Senator.
I was just gonna offer, last year, I believe it was, we did an update to this law. And I'd be happy to share with the committee my floor report from that. And also, with her permission, Senator Ayer's floor report from when Act 39 passed, because she shared it with me. And that gives you some historic, if that's okay with you, to share it with the committee. Yeah, it wasn't as I quoted,
It was a great report.
I quoted Senator Ayer in my report, so that, so that would give you some history of at least the Senate's work on this law.
That fixed some critical holes, like for instance, immunity. So the original law provided immunity for
Right.
physicians, but not pharmacists. So the department actually worked with the Office of the Attorney General to say, so long as the pharmacist is working within their standard of care, they're protected by immunity. But that was a critical law in providing some clarity and predictability.
Right. Okay, questions? We're actually 30 seconds ahead if we stop now. But anything else you'd like to add?
I think that's fine.
Okay, and if you have additional information that you've heard the questions, that would be great, just to get us some FAQs and comments. That would be awesome. All right, so Alex will go off live.